And welcome to the Ombudsman program. My name is Diane Welborn. I am the Ombudsman, and I'm going to be your host for this evening's program. I've actually been wanting to do a show on this topic for quite some time because of its seriousness and particular seriousness here in Montgomery County. Our topic tonight is infant mortality, which is a crisis point actually in our community. And I have with me guests tonight that are representative of a collaborative that is working to make improvements in this serious matter. So without further ado, I'm going to go ahead and introduce them, but I do want to remind our viewers that this is a call-in program, and I'm sure the number will be appearing on your screen. So if you have questions or a comment about anything we're discussing, feel free to join our conversation. Great. Well, thank you, ladies, for coming. I really appreciate your giving your time tonight to talk about the important work that you do. I have with me tonight Dr. Sara Paton, who is with Public Health, Dayton and Montgomery County, and also an associate professor at Wright State. Yes. Very busy lady, if you've got those two big positions there. And I also have with me tonight Marilyn McFadgen, who is the program administrator at Public Health, Dayton, Montgomery County, and also the project director for the Ohio Infant Mortality Reduction Initiative grant. Did I get that right?
Yes.
Okay, very good. So I think we should move right into some definitions about what are we talking about when we use the term infant mortality.
Well, an infant death is a death of a child before it reaches its first birthday. And it's an important measure of how we look at the health of our community. Not only is it tragic when you lose an infant, it's a reflection of the health of your community as well. And we use it in public health to look at not just infant deaths, but how our maternal care is, because it's related to the mother's health, it's related to the social welfare of the community and how much we put into that. Yes. It's also, do you have anything to add with that, Mel?
I think that pretty much summed it up. When you're looking for a place to move is how I always look at it. If a family is relocating, you want to look at how that community takes care of its most vulnerable citizens. So you would look at the infant mortality rate, and right now Montgomery County is not doing very well at all.
Okay.
And to calculate the rate, you take the number of babies that die divided by all the births in that community, and that's how you get the actual number.
Well, we've recently been in the news for our numbers, so why don't you give us a little bit of that bad news, those numbers?
Well, part of that bad news is that as of the 2011 data,
we have some slides to show it.
Yes.
Should I go through those three slides?
Let's go through the slides.
There's
They're
three
more
map
dramatic.
slides. The first map, please.
Okay, we'll start with the first map slide, and as the
US.
staff are getting that up in there, the first slide is a map of the U.S., and that will help us talk a little bit more about the numbers. Yes, there we go.
Well, this is looking at what our causes of infant mortality are.
Okay.
Do you want to talk about that first?
I think we should, since we have it right here. That'll be fine. We'll come back to the map when it comes up.
Sure.
In the next slide. Okay.
So there are a lot of reasons a baby can die before its first birthday. Some of them are preventable, and some of them are not. But if you can categorize them, some of the main reasons would be preterm births, and that means a baby is born too early, before its due date. Yes. And usually we categorize preterm birth as before 37 weeks gestation. Another big cause of infant deaths would be congenital malformations. So something can go wrong with the baby. Some of it is preventable and some of it is not. It could be a heart defect, it could be spina bifida, there are a lot of things like that. Then you also have other causes, SIDS. SIDS is sudden infant death syndrome, and that is part of an unexplained cause of death that happens in the first year of life. And you have problems that can go along with the mother during pregnancy, so maternal complications, and there are diseases of the newborn, there are accidents that happen, there's a lot of things that can cause deaths in a baby. But if you look at this slide, you can see by far and away the highest causes of death are preterm birth and birth defects.
If we can see that slide again, I'm going to let her speak a little more directly to what that slide tells us. If you all could, thank you for putting that up.
So this is the slide, and you'll see that top bars that are going across the screen to the right are birth defects, and the ones right below it are low birth weight and prematurity. And those are the two biggest causes of death. The blue bar is is a racial disparity. You can see that is the African American. The blue bar represents African American deaths, and the pink bar is everybody.
Is everyone.
So, and then after birth defects and low birth weight, you have SIDS, and then maternal complications. That could be something like diabetes, and then after that is accidents and various other causes of death, including accidents and various diseases.
Right. Okay. Thank you. I think we've finished with that slide
Right.
for now. Are some of the slides that you're showing tonight available at the Public Health Dayton Montgomery County website, so that later, if a viewer wants to go and take a look at these, they can find some of this data?
We have this and many more on
Okay.
our
All right. Very good. Just in case somebody was reading quickly and said, no, I want to look at that a little longer, they can go back and get it. That will be just fine then. Okay. Well, that gives us quite a big start, because we do have quite a lot of different causes of deaths of babies between birth and their first birthday, which is really how we're defining that right now. What are some of the non-medical contributions to deaths of infants between birth and year 1?
When we talk about the non-medical factors, that brings us to the social determinants of health. And I think we have a slide for that as well. Some of the social determinants of health are factors such as poverty, hopelessness, lack of education. There are some others: lower graduation rates, racism, poor working conditions, fatherless households, and limited access to care. And having said those things, one of the programs we have at Public Health, we have an outreach program that goes out to try to address some of these issues, to take some of the maternal stress off of the mother, to allow her to have a healthy birth outcome.
Okay. I think we'd like to try to find the next slide in that series, please, so that we can take a look at some of those non-medical factors and how they come in. We have an iceberg in front of us.
Yes.
So I will let you ladies tell us why we are using the concept of the iceberg to help us understand the challenges of infant mortality.
You take the top, I'll take the bottom.
Okay. Well, so the top, this is the first slide we talked about on the medical causes of infant mortality that we hear about a lot on the news: preterm birth and SIDS and congenital anomalies, birth defects. And why we have an iceberg is because this is just the tip of the iceberg on all the factors that go into causing an infant's death before their first birthday. And I think we can show the bottom of the...
Yes, we can show the bottom
We'll
of the
see
iceberg.
that slide again, the bottom of the iceberg, please.
The next one.
The next one, please. Oh my.
And these contribute to the social determinants of health: racism, housing, incarceration rates, unemployment, poor neighborhoods, fatherless households. These are the things that you don't really see, but all are contributing factors to maternal stress that can cause a poor birth outcome. Trying to address those things takes a community. Those are not issues that just public health alone can solve or attack on their own. So we need community involvement and engagement, which is what we are trying to do.
Okay. And along with that slide that shows so many of the items that are under the water that are issues just in our community, how does Montgomery County's infant mortality rate compare with, well, I'll let you take it, compare with the state? How does it compare? How do we compare with other states? Where are we on this measure?
Well, I'm the data person here, so I'll take the,
Okay.
the next slide. I think is a good start on where to go with the data. Can we get
Okay,
that up?
sure, we'll get, there we go.
So here we are. This is infant mortality by country. And if you look at this, you can see I've highlighted United States. We rank 28th in the developed countries, and that ranking can change a little bit by year to year and by who is doing the rankings, but we have been steadily going down in our infant mortality rates or rankings since the 1990s. And it's not a matter of us getting worse per se, it's that everybody else has gotten so much better, and we have stagnated over the last 20 or so years in our infant mortality rates.
So our rate is just staying the same.
Well, it is going down, and it depends on what population you look at, but we're not going down at as a high of rate as everybody else has been.
Okay, I see. And do you think that, would you say that our measurements are equal in such a table that has many other countries on it? Are we kind of all measuring apples in this thing, or the whole apple and orange kind
Well,
of thing?
there's a lot of debate on that, and
Okay.
I teach this in my class.
Okay.
So,
a short lecture, Professor, please.
a short lecture it is. There are some standard ways to calculate infant mortality, and not all the countries do it exactly the same way. For example, some babies that are born very small and have no chance of living in some countries might not be considered a live birth, whereas in the U.S. we are very liberal in our definition of a live birth. So any baby that's alive, even if they're only alive for a minute, is considered a live birth, and then that would be factored into the infant mortality. So you can have differences. Your infant mortality rankings can be influenced by this. But I have seen some literature that says even if you adjust for that, it might raise us a little bit in the rankings, but we're still doing very poorly compared to a lot of other countries.
Thank you. I did not intend my question to imply that somehow it isn't as serious as what it is.
No,
so thank you. But how, if we're ranking that way international, what about with among our states and our other cities, or however you all are comparing it?
All right, let's go to the next slide.
Okay,
we have three slides here to discuss that. Here's the disparities. Here's the actual numbers for the disparities. This is for black versus white. The next one must be the country one. Oh, here it is. Here we go. Okay, so this is how, if you want to look at the states and how they're doing for infant mortality rate, the green colors are the best, and the red and orange are the worst. And if you look, Ohio ranks 46 out of 50 states for infant mortality. And I always think, I would bet if I walked down the street and asked anybody on the street, do you think we're doing this poorly in infant mortality, they wouldn't realize that we are. And then the next slide that goes along with that is the white infant mortality rate. So if we look at the two major races we have in the U.S., our white infant mortality rate is one higher, or two higher. We're 44th, which is still
bad.
Is still very bad. And then the next slide. And this is terrible for black infant mortality rate. Ohio ranks 50th in the United States. So this is the worst place to have a baby if you're an African American.
Well, it's a very, very sad slide, but I'm glad you're here talking about it so that we can see what we need to do this about this. Are there the impact of race is clearly very dramatic, and I'm sure that the other socioeconomic factors that you have already identified kind of cluster with that as well. Would you like to say anything else right now before we move on in the show about the impact of race?
I would say one of the most startling things in Montgomery County that most people do not know is that for every one Caucasian baby that perishes, 3 African American babies die. And I think when you actually see a visual, which we have a display and we have actual shoes that would fit an infant, it has a greater impact. And I know just in casual conversations,
they have this now,
they
so
have
that
this slide.
as you're talking, the viewers can see this, that it's very dramatic.
It's very disparaging, and when people see it, they're taken aback, because you can say the infant mortality, morbidity, you can throw those terms out, and we tend to speak in public health ease, for lack of a better word. But when they see the shoes and they realize an actual baby has died that could have filled those shoes, that's when it has the greatest impact. But the sad part is, as Dr. Sara said, most people don't know that this disparity exists to this extent within Montgomery County.
Okay. Well, that is the job that you all are working on, is trying to inform people. And let's talk a little bit about what Ohio has tried to do to try to decrease the prematurity by 8%. This goal was set back a number of years ago, and we've reached now 2014, and they were hoping to have met this goal by 2014 to reduce the prematurity, which is the early births, which put babies at higher risk. How have we done in reducing the prematurity rates?
Well, we're only up, I'll show you a slide in just a minute,
Okay.
but we haven't done very well. We've only been getting worse through 2011. This is our first year at being 50th for Black infant mortality rate. I don't think we can get worse than that.
No.
So can I show the slide?
Before we go to the slide, we do have a caller, so I think we'll do that and then we will come right back to the slide. Yes, we have a caller waiting on the line with a question, so we'd like very much to hear your question. You're on the air.
Yes, thank you. I can't recall when I've seen a more important program, even though it's very alarming and sad. My question, in the midst of all of the charts and the data, I just want to have clarified and simplified for me what is the relative percentage of deaths due to genetic defects over against those that are caused by lack of proper medical attention, poor diet, in other words, social factors.
Okay, I think we've got your question, and we thank you for that. We'll get you the best answer we can. Thank you for your call. Okay, genetic factors versus other factors.
Well, that's a hard one to do because not all genetic factors can cause congenital birth defects that cause death, and we can't prevent some of those. But there are some of those birth defects that can be prevented. For example, good nutrition can help with having a good pregnancy, and folic acid can help prevent spina bifida if that does happen. And there is more of a genetic predisposition for some people to have spina bifida than others. So it's not always cut and clear when we're examining infant deaths. One of the Child Fatality Review Board's tasks is to try to determine if that death was preventable. And I would say about at least, well, I'm trying to remember the numbers off the top of my head, but a third of them are preventable, at least, of all the infant deaths. And that could be included of genetic defects as well.
So it is those 1/3 that are preventable, the topics which your outreach work is trying to address?
Right.
Okay,
Yeah, then that's exactly
the
what
third.
we work
Okay,
for.
so
Yes.
it's really about a third. Well, thank you very much. Now, before that nice question, we were going to be talking about moving toward a statewide goal of 8% reduction by 2014, and we had a slide that we were moving to show. Can we see that now, please? There we go.
So this is looking at Ohio data, and it's through 2013, and 2013 data is preliminary because in order to measure infant deaths, your babies have to have a chance to live a full year, so you have to wait till the end of 14 before you can get 13. And if you look at that slide, you can see that we have made some slight improvements in 2012 and in 2013 data. Whether it's 8% or not, we can't tell for sure yet until we get those data finalized. But you can see it's still, we have a long way to go. We've just improved slightly over the last 2 years.
Okay. And And it was in the last 2 years that our local collaborative was established, so that is encouraging. Why don't you talk a little bit about who is a part of the collaborative and what their mission is?
Okay. In 2012, August, Public Health Day in Montgomery County saw the seriousness of this issue and formed the Infant Mortality Collaborative. And that particular coalition is made up of almost every sector within Montgomery County. Education component, federally qualified health centers are represented. We have business, we have outreach programs. So we pretty much covered the gamut, and it's open to the community to come as well.
We have faith-based.
We have the faith-based community as well.
Parent representative.
Yes, we do.
The hospitals, insurance agencies.
You do have a very broad-based collaborative.
We do have a broad base.
Yes,
we
clearly. And given that we've seen the iceberg and we know that there are some genetic problems and then there's social problems and there are dietary problems and there's poverty and housing, that there's a wide range. Where is the collaborative putting their work across all dimensions, or are they focusing on certain areas?
Well, when we started up the coalition, before we decided we needed to thoroughly know what was going on in our community before we decided how we were going to tackle it. So myself and several other epidemiologists did a lot of data analysis, and we looked into what is Montgomery County's problem. Not just the state's, because there's so many different causes of death. We want to make sure we were tackling what is most
prevalent here
in our community,
right.
What's hurting our babies the most. And preterm birth, by far and away, stands out as the #1 cause of death for our infants in Montgomery County, particularly when you're looking at the disparities. Our mothers of African American babies are having a lot of preterm births, and the smaller that baby is and the younger that baby is, the greater chance that baby's going to die before their first birthday. So that's how we kind of decided. We also we had national partners that were helping us to look at our data and decide on what kind of initiatives would be most beneficial for us here in Montgomery County. Do you want to speak to that a little bit?
Well, we were a part of City Match, and City Match is a national organization that is striving for equity in birth outcomes. And as a result of that, we were a part of a collaborative with 3 other states.
Three
other cities, West Palm Beach, Baltimore,
San
Francisco.
We applied to be a part of
and
this.
we applied to be a part of that. And so we were in the unique position to be able to work and have the experts work with us to find evidence-based best practices that would impact the infant mortality rate within Montgomery County. The interventions that we decided upon here that seemed the best fit for us were centering pregnancy and 17P, or progesterone therapy. And progesterone therapy is usually prescribed for women who have had previous preterm birth or who have short cervical length. Centering pregnancy is a group approach to prenatal care and a little bit of postpartum care.
I'm going to come back to that,
Okay.
please. We have another caller that has a question,
Sure.
so we're going to come back where you were talking about centering and the partnership with the other cities. Yes, caller, thank you for calling in. We'd like to hear your question. You're on the air.
Hi, I was wondering what we as normal people, regular Daytonians, could do to help with this problem, whether it's prenatally or during the first year. What things can we do to help prevent this?
Thank you. Very important question. We appreciate your call. And now we'll get the answer. What can normal people do?
Well, there's a lot of things you can do, and I'll start with the before pregnancy.
Absolutely.
and you can tackle the pregnancy. Before pregnancy, one of the big pushes now is to get women healthy before they get pregnant, because pregnancy is only a short part of a woman's lifespan, and she may have a lot of health issues, stressors, economic issues that can impact her baby's health before that baby's even born. So one thing that public health is really pushing, it's called the life course perspective, and we need to have our young women healthy before they have a baby of their own. And that means not just right before they get pregnant, but we need to have young girls healthy, eating well, getting their vaccinations. We need to have the teenagers educated, and we need to push back this whole continuum, so we're not just focusing on prenatal care, and prenatal care is very important, but that's not enough. We've got to do more than just prenatal care.
I understand. So you're looking at overall health way prior to pregnancy, not just in the year before, but healthy coming into that. Yes,
Right.
and you were going to.
And
add.
while pregnant, Public Health has a program, Healthy Mommy, Healthy Baby, that is funded in part by the Ohio Department of Health. And that program does outreach targeting African American women who are at risk of having a poor birth outcome. So while pregnant, they go out, they educate the mom on the best ways to be healthy, take care of the stressors in their lives. And as we talked about the social determinants of health, some of the women that we run across in this particular program, to say to them, you need to eat healthy, you need to take some me time and take care of yourself, sounds very good, it's very effective. However, if that mother is in danger of being evicted, or she's in an abusive situation, those maternal stressors are taking precedence over everything else. So while pregnant, we try to educate them, and then we give them referrals throughout Montgomery County, agencies that are available to help them if they need shelter, if they're looking for housing. We try to alleviate that, and by doing the outreach, looking for women who present risk factors that could cause them to have a poor birth outcome, we work with them, stay with them throughout the pregnancy, and then stay with them until the child reaches 2 years of age to assess developmental delays and make the proper referrals. So there's so much that goes into having a healthy birth outcome, and spacing is another issue that is often overlooked. You will find a lot of young people in our program will have a baby, and before that baby reaches 1 year of age, they're pregnant again. It's not that the woman is uneducated or unintelligent. Sometimes things happen. It could be an abusive situation that she's in. So educating the mother, relieving the maternal stress, being there as an advocate on her behalf can help with a lot of the things that cause poor birth outcomes.
How many women are being served by the Healthy Mommy, Healthy Baby program in general?
Currently, we have approximately 60 women that we are seeing at this time.
Okay. And if there is a person out there watching the program this evening and they think they know a candidate for a Healthy Mommy, Healthy Baby, that maybe for some reason they think that their sister, their granddaughter or somebody that they know is at risk, what do they do?
They could benefit from just calling Public Health 496-7718, and that will link them directly with the Healthy Mommy, Healthy Baby program. And I should say that that program is staffed by registered nurses and community health workers who are certified by the Board of Nursing. It's built on the Partners for Healthy Baby curriculum that is founded in the principle that well-educated mom will be more likely to take better care of herself and have a healthy birth outcome. And many times we will find that the young mothers will go to the doctor, and the doctor will rattle off some terms that they don't fully understand, and there's that tendency to just nod. And sometimes they just need an advocate. So be that a community health advocate or one of our registered nurses, they'll accompany them to the doctor's office. Sometimes they'll get the white coat syndrome, we call it, and something they may have discussed with their community health worker or nurse, they'll forget about when they're at the doctor's office. And their advocate can say, well, we talked about you having a little problem with heartburn, or you're unable to sleep, or there's some swelling. And that gives them a sense of somebody has my back while I'm here. They're looking out for me. And that's helpful to the physician as well as to the mother.
Certainly it is. That's, and I'm sure you're measuring involvement with that program. I'm sure you're measuring the outcome of those babies. How's it going with that healthy mommy, healthy baby?
It is going, I have to say, really well. The Ohio Department of Health is very good with the data, and what they do periodically, as well as public health, we always collect data, is that we tend to kind of gauge ourselves by other Ohio infant mortality reduction initiatives throughout Ohio. Women in the program tend to have better birth outcomes than those who are not in the program, because you have a registered nurse or community health worker with you every step of the way. We have a male community health worker who works with the fathers to let them know that you are more than a paycheck. You are an integral part of the development of that baby and the health and welfare of the family. So if we can get those components together, that helps quite a bit.
Good, thank you. Now, before we went on that path, you were telling us about City Link, is it? City
Match.
City Match, thank you, and where West Palm Beach and San Francisco and Dayton, and that you had talked about best practices, and you were starting to talk about a centering approach. So why don't we pick up there if we can? Thank you.
The centering approach is, if you think about most women, when we had babies and we would go to see our physician, we had maybe a good 7 minutes with them. Centering is a group approach that has about 8 to 10 women. They're all around the same gestational age. They meet once a week and they get all of their prenatal care. They will see a physician. They are responsible for taking their weight, and I think they take their blood pressure. And then there is a midwife. Many times a social worker is there to address social needs, and there is a relevant topic that they will discuss during those sessions. While they're in those sessions, one mother may not feel comfortable in saying she's really having some problems with the whole pregnancy and feeling a little blue or the whole 9 yards. Another mother may bring that topic up. So there's a support system there. And if one mother doesn't come for one of the sessions, someone in the group will call and check on her. But you get everything at one stop, and you spend more time there than you would at a doctor's appointment, whereas a doctor may have to see you individually and say the same thing to 12 different mothers in the course of a day. He could say that one thing and impact 8 to 12 women at one time and get the message across and then discuss it in detail. And you might have something to add about centering.
Yeah, and it's not a lecture. It's everybody sits in a circle and they have a discussion, a facilitated discussion, where they can talk about some of the major issues that go along with pregnancy and having a baby. So they'll talk about relieving stress and substance use. They'll talk about breastfeeding, and the outcomes associated with centering have been shown to decrease preterm births and also increase breastfeeding rates, increase patient satisfaction, increase provider satisfaction. Because the providers, they all want to be able to spend all this time with their patients. They just simply don't have the opportunity. So this allows them to more fully engage with the patients, and the patients form this support group and learn a lot more than they would in a normal pregnancy visit.
Absolutely. And fathers and family members, you can bring someone with you. They're encouraged to attend. And I have to say, when I first heard of centering pregnancy, I couldn't understand how 8 women could be together and meet for this time frame, and you have individualized care and get your prescription. And Sarah and I went through the training, and you get it. I mean, it's a bonding experience. You're all around the same gestational age. Many of you are having the same problems, and you get to discuss it in a relaxed setting, and it's facilitated by trained professionals, and you walk away feeling like you've had a good experience. And so I could see my satisfaction level was up, and I'm not pregnant, but it was a good experience to go through, and you could see how it can really work to help young people.
Again, if there is a person that thinks that they would like to participate in such a centering group, how does one find it?
Information and referral at Public Health,
Okay, Public
225-5700.
Health. Okay.
We do have some partners that we are
Yes.
working with, and Five Rivers FQHC, they've gone through the training for centering, and they are working on moving towards that, so they will have centering in the near future. And then we have another partner, Life Stages, who's already doing centering, and they are available right now.
Right. And with calling Public Health, we will be able to link them with those particular facilities to get the information that they would need.
Okay, well, very good. That's an interesting project then. I wanted to give us a chance to talk about the other actions to try to prevent preterm births before 37 weeks. Is it? That's 37 weeks. There are probably some things that we didn't touch on earlier about
Sure.
that. So I want to return to that and see what activities our community is involved in to try to reduce that.
Well, there's a lot.
Reducing elective.
Do you want to talk that, or
deliveries.
I'll talk about progesterone.
You talk about progesterone.
So progesterone is an initiative that we're doing on a statewide level. That we have an association, the Ohio Quality OQPC, Ohio Quality Perinatal Collaborative. All these acronyms.
We have
It
so
fits.
many acronyms.
I'm
yes.
sure.
And they have been working on implementing progesterone use among women, and there's 2 candidates for progesterone, and this needs to be prescribed by your doctor. So early prenatal care is very important. The earlier you can get into prenatal care, the more quickly a doctor can identify you, not just as a progesterone candidate, but for other issues as well. But progesterone is proven to decrease preterm births in women who have had a previous preterm birth, and it can also decrease preterm births in those women who have a short cervix, and it decreases it up to 30 to 40%, depending on which condition you're talking about. And it is a series. It depends. It could be an injection once a week, or it could be a supplement that you take, a suppository that you take, and that is very effective at decreasing preterm birth. And OPQC is working very hard at getting that initiated throughout Ohio. Very important work.
And is it generally being accepted and adopted?
It is. Everybody accepts it and realizes that it's an important intervention. There are some quality improvement issues that need to be tackled. We need to get the pharmacies up and prescribing it, and we need to get women to their appointments every week so they can get their injections, and the women need daycare for their other children to go to their appointments.
So it's all the logistics.
Yes, there's lots of things
of
that go along with it.
administering that kind of therapy. Okay.
Yes.
All right.
And the only thing I would add to that is that elective deliveries, that's something that has been looked at so that women are not having babies delivered before their due dates or 37 weeks. That has been another issue. And to hear a doctor in our collaborative speak to that was interesting, because there are various factors and reasons why women will want to deliver early. So they have to take a lot of things into consideration, but the ultimate goal is to deliver a healthy baby.
Yeah, no elective births before 39 weeks is now the push.
Okay. All right. Well, it sounds like a very good one. again, with the coalition, I'd like to come back to the activities of the coalition because our viewers should know what's going on in our community, and they might find an angle or a way to enter or to get more information for themselves about that. So we've already talked about who is a member of the coalition, and you've mentioned that the public is welcome to come and observe meetings, is that, or participate, or
I think our health commissioner would welcome participation.
Okay. All right. So are the meetings times posted on the website, or?
They would be able to contact public health.
All right. Good.
And one of the things that I will say to our health commissioner's credit, we have regularly scheduled meetings, but if there is not enough on the agenda to really get into and for you to walk away with something, he will not hold a meeting just to hold a meeting. So you will walk away with something. So it would be best to contact public health to make sure the meeting is scheduled.
All right. So, and then we've already talked a little bit about the choosing of the interventions, but it sounds like we're kind of, are we still in process with that? Are we still choosing?
Well, we are. We're trying to get our centering and our progesterone up and running and do that well. And that takes time.
Yes.
Quality improvement issues take time. And we also need to communicate and talk to our community members as well and let them know about these interventions and get their feedback. And we have committees that are working on barriers for these interventions. So what kind of issues, some of them we've already mentioned. Transportation is always a big issue.
Child care is an issue.
How do you get to your appointments? And can you give the injections on your own? Or can all these little issues that people have that are a barrier, can they do this at work? You know, there's all sorts of things that people that you wouldn't even guess are worried about and have many issues.
And one thing we should say is that we have a communication team, and we have put together a logic model, and it is ever evolving because things that many of us take for granted are very problematic for many of the mothers. Transportation being a huge issue. Who will watch my child if I need to have these injections? How will I get there? So the collaborative is working together with many of the insurance companies to see how we can break through some of the barriers for women so that they can get the care they need to deliver a healthy baby. So with the communication logic model and the communications team, we want to be able to deliver the best message to the community in a very clear and concise way so that everybody wants to be a part of it. And in delivering that message, we're open for suggestions. What can we do better? How can we help the community? We need to all work together to get this message out, because I think once people know better, they tend to do better. And it's just a matter of getting the message out in the right way.
Raising education and awareness level,
Yes.
Absolutely. Well, of course, also, word of mouth is very important everywhere, and Montgomery County is no exception for that. So have we had a significant number of mothers going through some of these, the centering and the progesterone therapy, to be talking to others about that and spreading the word?
Well, they're both fairly new in the Dayton area.
Yes.
Life Stages has been doing this for a couple of years now, and they're being certified for centering as we speak. But their data looks really good, and I think they've seen 100 women. But they're trying to expand, and then if the FQHC will start centering soon. So yes, word of mouth is very important, because in centering, the Centering Institute will tell you that their biggest way of spreading centering is from women who have been in centering, because they absolutely love it and it makes a difference to them. So we're hoping for that kind of grassroots in the near future.
Yes, okay. Just having to get the word out there. What is the communication activity about all the matters we've been discussing for faith communities or schools or other entities in our community? How are we reaching out to them, or is that being planned for the future?
It's in the planning stages, and it's ever evolving. We have representation from all of those various facets on the Infant Mortality Coalition. But with the communication plan, we're still working on it because we don't want to deliver half a message. We want it fine-tuned, and we welcome input from the members of the coalition to tell us how to best address the various audiences. And I think even once we start to deliver the message, once we're out in the community, I think we'll find better ways to continue to enhance that message as we go forward.
Oh, very good. Are you all able to entertain or to respond to speaking engagements on this topic from groups that might be ready to hear you? Is there a speakers bureau, so to speak,
Yes,
that is
we
ready
do
to
have
go?
a speakers bureau.
Okay, and so they would just call the public health
Yes.
information number if a church group or somebody wanted to have a speaker. I know you want to talk to everyone, but if you could list some people, some types of groups you'd really like to get to, what might those be? Are you looking at teen groups? Are you looking at groups of 20-year-olds? What kind of groups would you really like to have invitations from?
I think I would say women of childbearing age, but the
Yeah,
younger, the better, with the life course perspective.
Right.
Okay.
And we want to talk to all sectors. So we've had a
Absolutely.
lot of presentations to other stakeholders, and we discussed the issue. And we even had a community forum in June or July as well for an area that we know has a particularly high infant mortality rate, to let them know about the problem. And we are welcome to talk to all community members, because it's not just one group that's going to fix it, it's all of us working together.
Absolutely.
Right, absolutely. Are there some slides that we didn't get to? I don't want us to run out of time when you brought some good resources. Was there other slides we have?
I think we're okay with the slides at the moment.
I think we pretty much covered it.
Okay, you've covered the slides. That's just great. What other goals or strategies are you all looking at that we have not talked about? Because this is such a broad and deep, as the iceberg showed us, topic. What are some of the other things that you all are studying, examining? You may not be working on them now, but they're in the pipeline.
Well, I can mention there's a few things going on at the state level that will help out our women as well. So,
Good.
for example, Medicaid, we're trying to make it easier for moms to get into their first prenatal visit. So a mother without health insurance, we're starting something in Ohio called presumptive eligibility. They can go to their first appointment without having to prove that they're pregnant and get all
Without
their
a card
paperwork
and
out.
without showing a
Right,
medical card.
absolutely.
Right,
Okay.
so we can
Absolutely.
get them into the first care as early as possible. So that's one thing that Ohio is working on as a state with Medicaid, and they're piloting it right now in some of the big hospitals, but it's going to spread as they work out all the bugs to get that worked out. So that will be great. So because that can be that can deter a mom from getting her first care until she's 3 or 4 or 5 months pregnant, if you have to go through all that
Absolutely.
paperwork to become eligible for health care. So that's one great thing that's going on.
I think the other is the Ohio Hospital Association with the Safe Sleep campaign,
All right.
that no mom should leave the hospital who doesn't have a safe sleep environment for their child.
And tell us
so
about a safe sleep environment. We may think we know what that is, but what is there a checklist, or what is a safe sleep environment?
pretty much safe sleep is alone on your back in a crib with no bumper pads, no stuffed animals, not in bed with mom and dad, a safe sleep environment just for the baby. And here, I think it's Children's Medical Center that has access to that. That if there's a mom who is in need of a crib or a pack and play for their child, they will contact Children's Medical Center. They will have a class, and then they will walk away with the pack and play so that their baby has a safe place to sleep.
And to what extent is that a problem for us? I don't know if you have numbers for Montgomery County. To what extent does that contribute to infant mortality?
It
The
does.
unsafe sleeping.
Unsafe sleep does contribute to infant mortality. It's a lot of our excess deaths that could be prevented. And it's used, the sleep environment is a really complicated.
You're right in the family there.
Right,
Yeah.
and and we don't have actually great data. Was the mom was the baby in the crib, or was the baby at home? Was the baby on a couch? And all these have different risk factors.
Sure.
So we're working on getting better data collection so we can know where should we start educating people on what is a safe sleep environment. Because we know, you should never sleep with your baby if you're a smoker or if you're using a substance, or you should never sleep in a couch or a recliner with a baby.
Okay. Well, those are very, very important things. Thank you for bringing that up. And you touched on something that we didn't specifically talk about, but we probably should, because we've talked about a lot of factors, but we didn't really specifically mention smoking, nor did we really specific.
We do have a smoking slide.
Okay, we didn't really talk about other drug and alcohol abuse and that impact, which I think is very generally known is not healthy. So, but we have a slide on smoking. Let's see, we have a little time to get that up while they're looking for that slide. Oh, we have it.
It's
I
right
see.
there.
Okay.
So this slide here is looking at the percent of low birth weight babies, or that's a preterm birth, that are born to a smoker versus a non-smoker. And the orange bars are the smokers, and the blue bars are the non-smokers. So you can see
Dramatic.
there's a dramatic effect of smoking on low birth weight or preterm babies. And smoking can have a variety of effects. Not only does it contribute to preterm births, it also contributes to SIDS quite a bit as well. So smoking.
And that's the sudden infant death
syndrome.
where one morning or the child just does not wake up.
Right.
And there hasn't been any other injury. The
Right.
child just doesn't awaken.
Right, and they think that smoking contributes to a lot of those deaths as well. And smoking can cause birth defects, as well as alcohol. Alcohol is another very harmful substance that can harm babies during pregnancy. Can cause a lot of congenital malformations. It can cause miscarriages, and a lot of permanent. Alcohol is one of those terrible substances that has permanent damage. So it's irreversible. You can't undo it once the damage is done.
Okay.
And public health can be contacted about fetal alcohol spectrum disorder. We have a social worker there who works in that particular area, and that's her area of expertise for children who are born to mothers who have drank throughout the pregnancy and the difficulties and disparities that they face once they're born.
And what type of stopping or smoking cessation kind of activities are available for women? Did I read that this is being offered in WIC clinics? Is this something that we can talk about here, about impact it's making?
I can't speak to the impact that it's making, but information on the quit line is made available to women in the WIC clinics, to women in the Healthy Mommy, Healthy Baby program. We give referrals for them to attend classes, to stop smoking. I know Public Health has a smoking cessation program that individuals could call Public Health to find out more about that.
Well, actually, on any of the topics that we've talked about tonight, more information can be obtained at Public Health.
Absolutely.
So why don't you give us that number again so we can have that out?
The information and referral line is 225-5700.
Okay.
And for Healthy Mommy, Healthy Baby, 496-7718.
Good. Wonderful. And the website for people, they can just Google Dayton and Public Health Dayton and Montgomery County.
They
right?
can, or
Okay.
www.phdmc.org.
Okay, wonderful. So people can get their questions answered and get their referrals made. We have very little time left. Do either one of you have something that I didn't ask you about that I should have, or a closing remark that you would like to leave the viewers with?
I think we just like to see every baby blow out the candle on their first birthday cake.
Well, that's a very nice thought to close with. So thank you very much. I
Thank
do
you.
appreciate your coming on the program, and I'd like to thank the viewers and the callers that joined the program tonight. Thank you.